I'm Jackie Persons. I'm very happy to give this talk as part of the ABCT Pioneers series. I feel honored to be considered a pioneer in our field. I want to introduce myself and describe my professional life. I want to talk about the contributions I've made that I feel most proud of. I want to say something about my training and those who contributed to my learning and my contributions. And I want to end by saying a little bit of something about the role of the ABCT in my professional life. So let me say I'm a practitioner. I've spent my entire career in private practice. My current private practice is called Oakland Cognitive Behavior Therapy Center, and it's located in Oakland, California, which is a fantastic city. I also serve on the clinical volunteer faculty at UC Berkeley in the Department of Psychology, where I have the great pleasure of doing some clinical training and occasionally some research collaboration with some of the students and faculty in the department. It's a fantastic option for me that helps me live in a larger scientific world in addition to in my clinical practice. I've been at UC Berkeley for now 20 years, and before that I spent 10 years plus at UCSF in the Department of Psychiatry in the same kind of a role. So the two contributions that I feel most proud of, my contributions to the development of ideas about case formulation in cognitive behavior therapy, and my modeling of and ability to, and most recently some writing about integrating science and practice by doing research in my clinical practice to study the change process and outcomes of naturalistic cognitive behavior therapy, including to do some research studies of my ideas about case formulation. So being able to join my clinical work and my research and make contributions in this way has been very gratifying to me. Let me just say a little bit about each. My ideas about case formulation, like all of my work, come directly out of my clinical work and my experiences as a clinician, where the current challenge and the challenge I've always struggled with is well described by this paper that I discovered recently, although I can't imagine I didn't read it earlier because it was published in 1992. It's written by Frederick Levine, Evelyn Sandine, Christopher Murphy. It's published in Psychotherapy. It's titled The Therapist's Dilemma: Using Nomothetic Information to Answer Idiographic Questions. So that title is a great description of the therapist's dilemma. Many of the dilemmas I encounter are exactly that. Patient is in my office. Patient has this and such idiographic, unusual situation. And then my job, what I'm trying to do is to use information from the scientific literature, which typically nomothetic information, to answer idiographic questions. And it's that kind of challenge that led me to thinking about case formulation and developing ideas about case formulation, case conceptualization, which has to do with idiographic thinking. So in a certain way, what I'm trying to do is to strengthen idiographic thinking by the clinician and idiographic hypothesis testing and data collection by the clinician, so that we can be doing evidence-based practice. We want not just to be drawing on the empirically supported treatment protocols, but we want to be collecting data and testing hypotheses in our clinical practice. And my first efforts to do that drew very heavily on ideas and thinking from the behavior analysts who had thought about this quite a bit more than I had, of course. Ira Turcat, Steve Hayes, Steve Haynes, many others who had thought quite a bit about functional analysis, idiographic assessment, idiographic treatment planning. And so what I did in trying to solve these problems in my own clinical work, where I was very much trained at first as a cognitive therapist. I was trained at the University of Pennsylvania. The first interventions I learned were Beck's cognitive therapy, which was being developed at the time I was trained. So I've been trying to use Beck's cognitive therapy for depression. And then I've got all these idiographic problems that my patients present. And so I went and read behavioral analysis and basically imported some of those ideas into my thinking about cognitive therapy. So that was my first book, which was published in 1989. My most recent book, which is published now kind of a long time ago, 2008, it's called The Case Formulation Approach to Cognitive Behavior Therapy. And what I did in that book was to add on the piece that's in almost the most important of all, which is data collection. So the formulation is like a hypothesis, and what you want to be doing as a clinician is to be collecting data, both process data, feedback from your patient, monitoring the change process, and outcome data, measuring symptoms and functioning ideally, so that you can test your formulation hypotheses and collect data to evaluate, is your patient accomplishing his or her treatment goals? And in that way, really, I would say you're doing evidence-based practice. And I guess I would say if you're not doing that, you are not doing evidence-based practice. And that is evidence-based idiographic practice. And that piece actually takes me very easily to my next contribution, which is my research piece, because to me, and I was fortunate enough to be trained to do this early in my training, the most exciting thing in the world is you're sitting in your office, you're meeting with and working with and hopefully helping a patient. And while you're doing that, you're collecting data to guide the clinical work. And if your patient gives you permission and you've gotten an ethical review of your project and your data collection, you can simultaneously make a contribution to the field and to our knowledge. And so I was fortunate enough to have been trained by Dr. Beck, who taught us all, when we're working with a depressed patient, for example, ask your patient to come a little bit early for the session. In those days, it was all paper and pencil. Fill out the Beck Depression Inventory, bring it into the therapist. I'm the therapist. I'm going to score the measure, make a plot of the scores. We're going to look at this plot together and use it to guide our work. So those data. And then I learned from Dr. Burns. David Burns was one of my first clinical supervisors. Can you imagine? Dr. Burns taught me, include in your treatment agreement a request to the patient asking you for the patient to give you permission to use your data in research. And most of my patients will agree to that. I also now have an IRB that helps me develop my procedures and evaluate the ethical bona fides of my projects. So if you have these pieces in place, you can, as a clinician, collect a lot of very valuable data that will allow you to make a contribution. And so I have done that, including to conduct some empirical studies of the inter-rater reliability of cognitive behavioral case formulation, a single trial effectiveness study of the benefits of case formulation-driven cognitive behavior therapy, comparing it to outcomes of protocol treatment for depression that was published in Behavior Research and Therapy, and another recent study also published in Behavior Research and Therapy. First author is Vail Gates, fabulous UC Berkeley graduate student, and several other colleagues, and evaluating benefits to outcome and dropout of a written case formulation in the clinical record, an idiographic list of treatment goals, a plot of progress monitoring data. So to me, the opportunity to do research in my practice and make a contribution to the larger field has been a very exciting part of my career, and one that I'm talking about here in particular because I feel proud of the way I've been able to do that. It's an exciting way to integrate science and practice, and I'm hoping to inspire some of the rest of you to, some of those of you who might be listening to me, to do the same. And please don't hesitate to reach out to me if I can be of any help to you. So those are my contributions. I want to say a little bit about my training. As you've already heard, many important people in the field have contributed to my training, and it reminds me to say that I am a privileged person. I'm a white person, and as you can see, I have had the privilege and good fortune to have some of the most amazing training opportunities in the world, and I just would like to acknowledge that and say thank you for that. I want to tell a little story about an important event in my training that I'm hoping might be helpful to some of you. I was trained at the University of Pennsylvania, where I arrived to study clinical psychology. I did my undergraduate degree at the University of Chicago. I studied anthropology. So I'm arriving. I know hardly anything about psychology, and I'm just starting to become a psychologist. I did my first year research project with a senior faculty person in the department who was studying thought disorder and schizophrenia. And his approach to doing that was to use a model of long-term memory that was developed by Saul Sternberg and a reaction time task developed by Saul Sternberg that when the patients completed this reaction time task allowed the investigator to identify which stage in long-term memory processing might be deficient for the patient or this patient population. And so I did my first year project using that kind of methodology and asking those types of questions. And then at Penn, after you do your first year project, you present your data and your results to your committee. My committee included Henry Gleitman, a cognitive psychologist in the department. Henry died in 2015. Henry said to me, Jackie, in your opinion, does it seem to you that the deficits in the symptoms of formal thought disorder that you're seeing in these patients are likely to be accounted for by these deficits in long-term memory that your research studies are examining? What is your opinion, Jackie? So I don't remember what I said at the time. That was a long time ago. But the fact is, the answer to that question was no. And what Henry was saying to me was, Jackie, think for yourself. Don't be doing a research study and don't be studying hypotheses that don't make sense to you and that you do not believe in. Think for yourself. And so that was a gift to me. Although I have to say it was completely terrifying because I knew if I followed that original path, I could get my PhD and finish the program. But if I didn't do that, I felt terrified. But was I going to be able to think for myself? Was I going to be able to get ideas that are worth pursuing and do a project worth doing? But I decided I was not going to be keeping doing that. Anyway, so I started thinking. I read Chapman and Chapman's book on disordered thought and schizophrenia, which described all the major theories about cognitive mechanisms underpinning formal thought disorder. And to my great fortune, Jonathan Barron, who was a cognitive psychologist in the department, agreed to work with me, and he helped me develop some small reaction time tasks to test these hypotheses of these theories. And I took them out to Haverford State Hospital, and I collected data, and I did a research study that produced a lot of negative results, but got me my dissertation, and I was able to publish my paper and set me on my way to have the courage to think for myself, develop my own ideas, and started me actually thinking about cognitive underpinnings of symptoms, which actually is very tied to case formulation and my clinical work. So I would like to say thank you to Henry Gleitman and Jonathan Barron and so many others who, many of whom I have not been able to name here, but who contributed to my training and development. I would mention that after my opportunities to learn in the Department of Psychiatry at the University of Pennsylvania, I also had the opportunity to do a postdoctoral year of training at Joseph Wolpe's Behavior Therapy Unit, where I also learned from Edna Foa. So exciting. I feel grateful to have had all those opportunities. So that's my training and I want to say something about the ABCT. I want to say one other group that's contributed to my training is a group of clinicians who reached out to me, and somehow we got together about 10 years ago, and we formed our own institutional review board. And so this is a group of clinicians who, like me, are doing research in their clinical practice. And we formed our own IRB, the Behavioral Health Research Collective, IRB. Travis Osborne is our chair, and who carries the load for us in many ways. And that group has been a major foundational support for me that allows me to do research in my practice. Let me say something about the ABCT, which also has played a major foundational role and allowed me to do research in my practice, because going to the ABCT, attending the talks, meeting people there, presenting, keeps me in touch with the national community and the scholarly and scientific community and body of work in our field that if I just sat in my clinical practice in my office in Oakland, I would not have. So I attended my first ABCT in 1981 when I was a postdoc. We were in New York. I tagged around with Edna Foa, who introduced me to everybody. I was completely intimidated, but I could see that this is my group. And so I came to the ABCT that year, and sometime early on, I decided my rule for myself, for my professional life, is I go to the ABCT every year and I present. And so I have done that, and now I'm coming up on my 40th meeting, and I have a group of friends and colleagues that are very important and special to me, even though we really only meet once a year, and that are the foundation. Like when I write a paper or write a chapter or write my books, I'm writing to my ABCT colleagues, to the students who I know are there, and so that helps me guide my thinking. I learn so much at those meetings. Recently, I started a group, a special interest group at the ABCT. It's called Research in Clinical Practice. So I'm hoping this group, which now has over 70 members, fantastic clinicians who all want to do research in practice, can also provide for me, and I'm hoping for others, a foundation that allows us and them, all of us, to make contributions to the field. So let me say thank you so much for the opportunity to describe my career here, and I'm hoping it might be useful to those of you who are hearing me present it here today. Thank you.